Next we have McCusker and Frtiz.
All right, good morning, or afternoon actually. Today we will be talking about PET-CT versus CT in patients with non-Hodgkin's lymphoma, a student's perspective. I'm Frtiz.
And I'm McCusker. At the end of this presentation, the audience will be able to define non-Hodgkin's lymphoma,
Recall how CT, PET, and PET-CT are used in non-Hodgkin's lymphoma, and describe the comparative findings between CT and PET-CT in patients with non-Hodgkin's lymphoma.
This is cancer of the lymphatic system, and it is found in the lymph nodes and anywhere lymphocytes flow, and also any of these major body parts.
These are the symptoms, which are very vague and ordinary. Therefore, recognizing these symptoms can aid in the diagnosis of the disease, and because of this, there is no screening process available.
And these are the imaging modalities that are available for staging. We studied specifically CT and PET-CT.
I'm in trouble with this. The primary choice for non-Hodgkin's lymphoma is CT. This provides anatomical location, or where the lesion is found. It shows the lesion size and shape with a tool used by the reading physician's computer program, and the detection of extranodal sites. For example, a malignant lesion in the liver of a non-Hodgkin's lymphoma patient is considered an extranodal site. CT cannot be used exclusively for staging because early involvement is not always detectable. Benign node enlargement reveals false positive results, which means the test results say that the patient was diagnosed with non-Hodgkin's lymphoma when they actually do not have the disease. And CT cannot distinguish between tumor and scar or necrotic tissue.
CT does provide high sensitivity and specificity in initial staging only. Now for positron emission tomography, this works by intravenously injecting a positron-emitting radiotracer, fluorine-18 fluorodeoxyglucose, into the patient. The radiotracer is a radioactive glucose taken up by areas of the body that use glucose metabolism, such as the brain, the heart, the kidneys, and anything else that naturally uses glucose.
Cancer cells have high glucose metabolism, which is why they are able to see areas of lymphoma with F18 FDG. Unlike CT, PET provides high sensitivity and specificity in initial staging and restaging.
Now the first image is a PET image, and it shows a healthy patient with areas of normal increased uptake, the black spots that you see, in the brain, the heart, and the bladder. And the second image on the right is a patient with non-Hodgkin's lymphoma. The areas of abnormal increased uptake is the cancer.
PET and CT images are fused together for precise location and accurate depiction of malignant or benign lymphoma tumors. This allows for shorter acquisition time because the patient does not have to move between the two imaging modalities.
The comparative findings between CT and PET-CT in patients with non-Hodgkin's lymphoma, a student's perspective, will be addressed because these imaging modalities alone may not always produce the same diagnosis.
20 patients were included in this research, and all of them underwent a PET-CT scan with F18 FDG. 10 patients underwent initial staging, while the other 10 patients underwent restaging. All images were retrospectively reviewed by us with a physician certified in radiology and nuclear medicine.
We used an Abbott lab glucometer for testing blood glucose level, and we used a General Electric Discovery VCT PET-CT scanner to take the images.
Prior to the injection of the radiotracer, prescribed patients were asked to drink a large glass of gastrografin, an oral contrast used for CT to visualize the GI tract, mixed with crystal light. Also, an intravenous catheter was set with a minimum of a 20 or 22 gauge needle which means the smaller the number, the bigger the needle.
All patients were dosed with 10.8 to 22 millicuries of F18 FDG.
Once injected, the patients were taken to a dark room where they had them relax for 45 minutes to allow for maximum uptake of the radiotracer.
We set a timer to go off after the first 20 minutes, and this reminded the patients to drink the second glass of the gastrographin, which is the oral contrast that we had them if they were indicated for it.
We visually assessed each CT image in the RAD assessment computer program, and we took note of areas with abnormal size of lymph nodes or above 1 centimeter. How many lymph nodes are in the one area of the body and abnormal Hounsfield units, values, and organs. A computer program is used when looking at the images and utilizes a ruler to measure the lesions and also draw circles for the Hounsfield units.
On our fused PET CT images, we noted areas of increased uptake that were not identified on the CT images. And then when we talked with the physician, he confirmed or corrected our observations, and then he explained each patient's diagnosis in detail.
We divided our patient demographics into initial staging and restaging charts for easier interpretation of a large amount of information. Patients 1 through 10 were initial staging. We provided their age, gender, and blood glucose level.
And these are our restaging patients, also 10 of them. We found that non-Hodgkin's is not specific to any age or either gender in our research, and we made sure that all of our blood glucose levels were below 200 so we can be sure that we had quality images.
Along with our patient demographics, our results were also divided into initial staging and restaging charts. Because there was so much information per patient, we divided the CT image only into sections of above and below the diaphragm. Any areas of increased uptake that were seen in the PET CT images that were not already noted in CT were used for research statistics.
And these are the results for our patients that underwent restaging scans. These patients have had chemotherapy and radiation therapy treatments, so some do not present as many lesions or areas of malignancy as our initial staging patients.
Once we reviewed our research, we divided them into 4 categories. And these are the categories. 40% of our patients in the PET CT images confirmed the suspicions detected in the CT images, except for patient 8. Patient 8 was the only patient that did not have a mass or lesion, but did have a lumpy gastric wall. The PET CT image confirmed there was increased uptake in the gastric wall, and it was positive for lymphoma.
The majority of our research, about 45%, proved the PET CT images added diagnostic information to the individual CT images. More than half of this category of patients underwent initial staging scans. Many of the patients had undetected malignant masses in their CT images. However, the areas most commonly missed in initial staging was bone marrow, with no way of detecting its malignancy without the addition of PET, except for patient number 15. He was a restaging patient and the only one with a malignant bone marrow, and this proves that PET CT is necessary for accurate staging regardless if it's initial or restaging scan.
20% of the patients from added diagnostic information was dependent on the PET CT images because CT alone did not provide sufficient information. Bone marrow involvement changes the stage of lymphoma based on Ann Arbor classification. Therefore, patients would not have received proper treatment based on the CT images alone. Patient 5 CT images were completely negative, so if he were not to have underwent a fused PET CT image, he would not have been able to be treated, and this would have been a false negative study because the PET CT image revealed increased uptake in the gastric wall of the stomach.
And the last 15% of our patients, which were all restaging, were negative for both imaging modalities. They were patients 17, 18, and 20. Even though CT is the first choice for initial staging, PET CT provides additional diagnostic information, can be diagnostic dependent based on the images, and can ultimately alter the patient's treatment.
When comparing CT images alone to fused PET CT images are most useful in patients undergoing initial staging scans. However, they cannot be ruled out for restaging. PET-CT is the most accurate and dependable imaging modality, regardless of staging type.
And we would like to extend a special thanks for aiding in this research to Professor Donna Mason, Dr. Ashok Muthakrishnan, Dr. William Wentling,
Dr. Angela Macy Byers, Certified Nuclear Medicine Technologist Connie Moore, and the facility of UPMC McGee Women's Hospital and UPMC Hellman's Cancer Center.
for our reference.